Morning, everyone. Hello.
Hello, Doc.
Hope you can see the title, Skeletal Dysplasia. Okay, then let's move on.
Okay.
I know the topic reads bone dysplasia, but usually you remember bones don't work alone. They work together with other tissues, and that's why the bigger title should read Skeletal Dysplasia. Now, this is a very wide topic. So we will go around it, and then we are going to common than the others. And even in your practice, these are the two conditions that you'll mainly come across. Now, these are heterogeneous group of disorders comprising of abnormalities of bone or cartilage growth, or the text. They actually, most of them occur due to genetic mutations. And overall, the prevalence is between 2.3 and 7.6 per 10,000 births. Now, any bone may get involved, and this causes disproportionate short stature. There is physical deformities. Actually, most of the patients with these conditions will tend to have short stature. Now, skeletal dysplasia is the medical term for what many people will refer to as dwarfism, and that's what I've referred to as the short stature. It's actually an umbrella term that can affect a child's bone and cartilage. The development is interfered with, and this is what causes the short stature. Now, types of skeletal dysplasia are generally classified by which parts of the skeleton is involved. When we talk of part of skeleton, it may be the spine or the lower limbs. Now, a child born with skeletal dysplasia will have abnormal differences in the size and shape of the various parts of the body. It may involve the legs, the arms, the trunk, or even the skull. And they may be very short in stature. They may also have with the rest of their body. Their dwarfism, disproportionate symmetrical decrease in both the trunk and the limb. They are terms that we usually use when there is shortening, depending on which part of the body is affected. And you can see from that picture, the proximal part, the term rhizomelia will be used. When it's the middle part, then you have the mesomelia. And the distal part, we use the term acromelia. And if it's the entire limb that is involved, then we'll use the term micromelia. Then and the ulnar part, when it's the radial side, then we refer to that as the pre-axio, and then post-axio is the opposite of that. Now, this skeletal dysplasia, majority of them are usually very rare. You'll actually read many of them in the books, but they are very rare. Are the ones which are more common and the ones you'll come across. Now, for appropriate diagnosis, of course, the patient will present to you. So there is the history. Then you're going to examine the patient clinically. You also need to find out about the family history, as to whether there is. But you realize that actually majority of them, you may not even get somebody in the family who has suffered from this. Then, of course, after your physical exam, you want to do your radiological examinations. Then you don't need to stop there. You need to move further so to study the molecular and biochemical tests. These are basically just to confirm the genetic. Again, to define further terms, dysplasia, these are disorders with generalized abnormality of the skeleton. And the phenotype tends to continue and evolve throughout the life. Then you have dysostosis, and these are disorders with abnormality of a single affects the bones alone. And this is thought that the phenotypical behavior of it tends to remain static throughout the life. So at the dysplasia, in dysplasia, the thing is just evolving as the individual grows up. But the dysostosis is actually thought that it's static. What are the symptoms of skeletal dysplasia? Specific symptoms of skeletal dysplasia vary depending on the disorder that the child has. As I said, it's a variety of conditions, many of them. So it will all depend on which part of the skeletal system is affected. And this could be the arms or the legs, the trunk. Will develop with unusual shapes, size, or both. Now, besides that, other symptoms that may be seen will include stubby fingers, duplication of the fingers or the toes, club feet, missing limbs, missing ribs, fractured bones, joint pain. There may be developmental delays. Again, they may have cognitive impairments, previously known as just mental retardation. Now, what are the causes of skeletal dysplasia? Skeletal dysplasia, majority of them are actually inherited by many different types of genetic mutations, which are passed down from the parents to the children. Now, these genetic mutations, they don't necessarily need to affect the parents or even the grandparents. So the parents will actually be normal, but then you find the child is abnormal, or the parent may be affected and then they also pass it over. Skeletal dysplasia runs in families. one can potentially pass the condition to their children, even if they don't have a known family history of it. Now, the exact genetic defect responsible for a child's skeletal dysplasia may be difficult to pinpoint. Now, the most common type of skeletal dysplasia is what we call the achondroplasia. And this is known that it's caused by mutations of a child's FGFR3 gene. Now, these figures, we're going to mention several figures as we move on. Yeah? I hope they won't disturb you. Of children born with achondroplasia have normal height and stature, as we stated earlier on. Now, there are other types of skeletal dysplasia. Thanatopic dysplasia is a condition that causes a child to develop extremely short limbs, and they have underdeveloped lungs. Then there is hypochondroplasia. And this is a condition that affects the conversion of cartilage into bone in a child's body and results in short arms and legs, as well as the hands and feet. Yeah, they are short and they are broad. Then this is often fatal in newborns and causes dangerous bowing of the long bones in a child's legs and often their arms as well. So they tend to be bowed. So osteogenesis imperfecta is a disorder that results in fragile bones. So the first one I mentioned, that is achondroplasia, and then osteogenesis imperfecta. These are the two conditions that we're going to discuss a little more because they are the ones which are more common and they're the ones we come across. Achondrogenesis is a disorder that causes a child to develop short limbs and a very small body. Diagnosis, as we mentioned earlier on, if a child has skeletal dysplasia, as we said, many of them will be born with short stature. In other cases, they may be born with normal stature, but they fail to grow normally. Then, as I mentioned, there may be a family history. You also need to measure the child's height, weight, and the head circumference. Measure the lower and the upper segments of the child's body separately to assess their proportions. Imaging investigations, we usually use plain X-rays, further investigations including CT scan and MRI because you want to get more details. Ultrasound examination may be done actually earlier during pregnancy, and this may pick the dysplasia in utero. The exact type of dysplasia may be difficult to diagnose until after. As I said, you need to go further to genetic and molecular analysis to help identify the type of skeletal dysplasia that the child has. So this can help identify the exact genetic mutation that is causing the condition. What about treatment? Now, treatment of these children is usually, and the specialists may include neurosurgeons, neurologists, orthopedists, ophthalmologists, endocrinologists, radiologists, geneticists, physical therapists, occupational therapists, and many others. It's not only the orthopedic surgeons who are going to deal with this. Growth hormone to promote their growth. Then there are situations where we need to do surgery. And there are many possible complications involved in this type of surgery. Again, it may involve multiple procedures and a long recovery period. In other words, it's not very easy to deal with these children because the surgery can actually cause more harm than good. So we have to do very good assessment and make sure that whatever we're going to do will be helpful to these children. Rehabilitative therapies to help relieve the patient's symptoms, increase their independence, and improve their quality of life. Physiotherapists and the occupational therapists. Prognosis will basically depend on the type of dysplasia the child has. Now, according to Children's Hospital in Philadelphia, about half of the fetuses with skeletal dysplasia are stillborn or they die shortly after birth. Condition will survive into childhood, and then a few will survive into adulthood. Now, for those who survive, many of them tend to live a relatively normal life. So that there is that natural selection, so that those who are weak are actually eliminated. Now, that is just a list of the many conditions that fall under this topic, skeletal dysplasia. There's a chondroplasia, cleidocranial dysplasia, and all that. And this does not actually exhaust the list. There are many, many others. And as I said earlier on, majority of them are rare. Let's talk about achondroplasia. And this is the most common hereditary form of dwarfism. Incidence rate is about 1 in 15,000 and 1 in 40,000 live births. It is fully penetrant autosomal dominant disorder. The majority of the cases, 75 to 80%, mutation. As we mentioned earlier on, the autosomal dominant point of mutation is FGFR3. Stands for fibroblast growth factor receptor 3. The mutation occurs in nucleotide position 1136 of the cDNA. A translation or a G to C transversion on the chromosome. I know those figures are not very easy to remember. We will not bother you with all those figures, but it's just good for you to remember that it's a gene that is converting, getting to the wrong side, and then leading to the condition. 80% family history, as we mentioned earlier on. The mutation is associated with an increased paternal age at the time of conception. This time it's paternal. It has been demonstrated that the mutated allele is always from a paternal origin, not maternal. And they are associated with somatic mutations at the same gene FGFR3, seborrheic keratosis. These are mainly skin growths, epidermal nevus, and urothelial carcinomas. Yeah, carcinomas of the urethra. Hypoplasia affected individuals have short stature in arms and legs, but the torso, that's a trunk, usually is normal. Other skeletal problems that they usually have are trident hands, mid-facial hypoplasia, prominent forehead, that is bossing of the frontal bone, hunched back, and they have narrowing of the spaces between the pedicles of the vertebra. That is to show you a picture of a patient with achondroplasia. You can see this guy is short, the trunk is normal, but then the limbs are short. Again, that's an X-ray of a patient with achondroplasia. And you notice the femur and the tibia bones, they are actually short. And on the right side, you can see some surgery which has already been done there, and a plate has been put in place. Overall survival and the average life expectancy for achondroplasia population compared to someone who does not have this condition. These patients are usually at risk of heart conditions, and the bone abnormalities of the spine, like narrow foramen magnum and spinal canal stenosis, affect mortality at all ages, but particularly in children. Normal intelligence. Prenatal diagnosis and genetic counseling. There is some obstetric risk for the mother and child. Fetal diagnosis of achondroplasia is made with certainty when diagnosis of achondroplasia is usually first suspected later in gestation on the basis of long bone foreshortening incidentally discovered during ultrasonography. They are disproportionately short limbs which are seen even with heterogeneous conditions. Now, genetic confirmation can be performed with chorionic villi sampling or amniocentesis. And as we said earlier on, an ultrasound has been done, then you want to go further to get chorionic villi and then the amniocentesis. That's why we said that if the diagnosis has to be made at this stage, then you want to do counseling to the parents. Because of these invasive procedures, then there is a risk to the mother and also to the fetus. Below there says that recently non-invasive maternal blood tests have been developed. They have not reached our country as yet. What are the current medical treatments for chondroplasia? Surgical, and this involves lengthening procedures of the long bones, where we use the respective bones. And more favorable and significant increase in height have been obtained, but of course it's over a long period of time, 18 to 20, that's a whole 2 years period. So you can see it's quite a lengthy procedure and follow-up. Let's talk a little bit about osteogenesis imperfecta. And this is also called the Preto bone disease. Other terms that are used are the fragilitas ostium orolic disease. And the brittle bone, the compact bone is actually reduced, and what we have more is actually of the spongy bone. Just to show you a picture of some of the children who come with osteogenesis imperfecta. And you can see the now, as I said, osteogenesis imperfecta is actually more common compared to the other conditions, and you will definitely come across them when you start practicing. So osteogenesis imperfecta is a group of genetic conditions or disorders that mainly affect the bones. Perfect bone formation. And people with this condition have bones that break easily, often due to mild or sometimes even there is no trauma, but then the bone just breaks. Multiple fractures are common, and in severe cases, they can actually occur even before birth. Fractures. Milder cases may involve only a few fractures over a person's lifetime. There are at least 8 recognized forms of osteogenesis imperfecta, and they are designated as type 1 through to type 8 are usually distinguished by their signs and symptoms, but their characteristics or the symptoms may actually overlap. Type 1 is the most mild form of osteogenesis imperfecta. Now there is that capacity. Can someone advise how I'll get rid of it? It's okay. So as I was saying, type 1 is the mildest form of osteogenesis imperfecta and type 2 is the most severe. Other types of this condition have signs and symptoms that fall somewhere between these two extremes. Increasingly, genetic factors are used to define imperfecta. Now, people with mild forms of this condition typically have a blue or gray tint the part of the eye. That's a white part, the sclera, and they may develop hearing loss in adulthood. Affected individuals are usually of normal or near normal height. Osteogenesis imperfecta are more severe, causing frequent bone fractures that may begin before birth and result from little as or no trauma at all, as we mentioned earlier on. There are additional features of these conditions, and as I said, they may include blue sclera, short stature, hearing loss, respiratory problems, and a disorder of osteogenesis imperfecta. Now, the most severe forms of osteogenesis imperfecta, particularly type 2, which we mentioned earlier, can include an abnormally small, fragile rib cage and underdeveloped lungs. And infants with these abnormalities, sometimes they get life-threatening problems with breathing. Birth. It affects an estimated 6 to 7 per 100,000 people worldwide. Type 1 and type 4 are the more common ones, and they affect 4 to 5 per 100,000 people in the world. Mutations, these are more figures again. COL1A1, 1A2, CRTAP genes that cause osteogenesis imperfecta. COL1A1 and then 1A2 genes are responsible for more than 90% of all cases of osteogenesis. Provide instructions for making proteins that are used to assemble type 1 collagen, which is the main element you'll find in bones. This type of collagen is the most abundant protein in bone, skin, and other connective tissues that provide structure and strength to the body. So most cases of osteogenesis imperfecta have an autosomal, which means one copy of the altered gene in each cell is sufficient to cause the condition because it's autosomal dominant. Many people with type 1 or type 4 osteogenesis imperfecta inherit a mutation from a parent who has the disorder. Less commonly, osteogenesis imperfecta has an autosomal recessive. This just means 2 copies of the gene in each cell are altered. Now, the parents of a child with an autosomal recessive disorder typically are not affected, but each parent has to carry 1 copy of the altered gene. How do we treat osteogenesis imperfecta? Osteogenesis imperfecta. Whatever we use are just treatments to help with symptoms and to improve the condition of the patient. We try to make sure that bones are healthy as possible, and advise the parents on the type of food that they give. Then we usually use bisphosphonates. But in extreme cases, then we have to go surgical. And of course, the dentists also step in because of the dental conditions that you mentioned earlier on. Many times we have to use intramedullary rods in these bones because they tend to get curved. So usually do what we call osteotomy, realign them, and then we put the rods, one as a form of treatment, and also secondly as a prophylaxis. So that then we prevent the child from getting very many fractures. So we put rods in the long bones and strengthen them to prevent deformity and fractures. Just to show you what I've just mentioned about rods, you can see those bones are bowed and then rods have been put in. Of course, you realize we will put the rods at the age of 2 or age of 3. Then the child will grow, they are going to outgrow the rods, and sometimes we are actually forced to do several surgeries before the child becomes mature. Wish to stop there. Are there any questions? Hello?
Thank you, Dr. Kingori. I don't think there are any questions in the chat box.
Okay. Thank you very much then. Have a good day.
You too, doctor.
Okay.
Recording stopped.